Hello, my name is Dr. Seidu. I'm a clinical lecturer at the University of Leicester and a part-time GP in Leicester City. These are my disclosures. Right, so I'm going to be talking about implementing guidelines in the primary care setting, and I will consider the topic under the following items on the agenda. First of all, I will talk about diabetes in primary care, and then I'll move on to talk about comparisons between primary care management of type 2 diabetes with specialist care. And then finally, I'll move on to addressing the efficacy gap, and I'll address the causes of this efficacy gap. So the rationale for clinical guidelines is to address the heterogeneous level of outcomes achieved by various centers across the world. Type 2 diabetes prevalence is rising exponentially across the globe, and the vast majority of patients with type 2 diabetes are now managed in primary care. With the rising prevalence comes rising healthcare costs, and this leads to increased health expenditure. In areas where there are poor outcomes, the healthcare expenditure can actually be a lot higher. So the purpose of guidelines is to facilitate a consistent and effective and efficient practice and improve these health outcomes in patients. The guidelines are actually developed to assist practitioners to make those decisions. They do not replace your clinical judgment. They are systematically developed statements to assist practitioner and patient decisions about appropriate healthcare for specific clinical circumstances. And as I said, the key word is assisting you. They don't replace your clinical judgment. They are more crucial in recent times because over the past 30 years, or probably about 30 years ago, the vast majority of patients, even though we're managing primary care, about a quarter were still managed in specialist centers. Fast forward in 2020, only about 5% of patients with type 2 diabetes are now managed in specialist centers, which means that the remaining 95% of patients have got to be managed by a well-informed, well-educated, guideline-abiding primary care healthcare professionals to prevent variations in the health outcomes that I've already mentioned. So how does primary care management of type 2 diabetes compare with specialist care? Well, about over probably 20 years ago, a comparison was made in a detailed systematic review looking at studies on this topic. And as you can see from the forest plots on the screen, apart from one study that favored hospital management of type 2 diabetes over primary care, there was no difference at all between patients with type 2 diabetes managing primary care versus those managing specialist centers. Indeed, one study actually favored primary care centers have done a better job in managing type 2 diabetes compared to specialists. The reason for that could be because patients managing primary care centers usually are more stable patients without a lot of the complications that make it more difficult to achieve glycemic targets. So a structured vignette questionnaire was conducted in Australia a few years ago on GPs and expert endocrinologists managing type 2 diabetes. And in that questionnaire, even though the GPs acknowledged that they were following guidelines all of the time, when it actually came to specific interventions recommended in the guidelines, they found that the GPs were less likely to adhere to these specific recommendations in those guidelines. For example, when it comes to lifestyle modification, 82.3% of the GPs interviewed agreed that they were going to offer lifestyle interventions to patients who really needed it, compared to 96.5% of specialists. Similarly, for hypertension treatment, patients who had blood pressure above target that needed augmentation of their medications, 66.7% of GPs admitted they were going to do this, compared to 89% of the specialists. And similarly, we started prescribing for those patients who were at very high risk of cardiovascular risk. 68.5% of the GPs admitted, they were going to prescribe statins compared to 73.6% of the specialists. So it appears that even though primary care clinicians admit that they follow the guidelines, when it comes to actually implementing specific recommendations proposed by the guidelines, they actually are less likely to do that compared to their specialist colleagues. And this less likelihood also varies from one GP practice to another GP practice, one city to another city, and one country to another country. In the guidance study across Europe, which interviewed primary care teams across 8 European countries, what was consistent is that GPs consistently measured hemoglobin A1C when it was time to do that. But when it actually was time to actually do something about this elevated A1Cs, they were less likely to do that. And there was some variations across the countries, with a country like Italy doing far worse compared to countries such as the Netherlands and France, where the GP did a lot better in putting interventions in place to achieve glycemic control. So there is a difference between the A1C levels that we get when we look at studies in randomized control trials compared to the A1C levels that are actually achieved in the real world setting. And that gap between A1C levels achieved in the randomized control trial versus the one that we achieve in real world setting is called the efficacy gap. That efficacy is unrealized. And there are a lot of reasons why this could be, and key amongst those reasons would be this non-adherence to the guidelines. Bearing in mind that these guidelines are always developed based on this evidence from the randomized control trial. So if there is a gap between what is realized in the real world versus what is realized in the clinical trials, it is the fact that GPs or healthcare professionals and their patients probably are not adhering to the recommendations in the guidelines. Chiefly amongst these causes of this efficacy unrealized or efficacy gap is multimorbidity. So GPs, unlike other specialists, do not just manage specific problems. So if you are a GP and you have a patient with diabetes, that patient with diabetes may have a lot of other comorbidities. Now, if you are a specialist, all you have to worry about their diabetes, augment your anti-diabetic therapy, and then refer them to the cardiologist or respiratory physician if they are COPD and so on and so forth to also deal with the rest. So you only, as a specialist diabetologist, have to be aware of the guidelines in diabetes. The GP, on the other hand, has got to be aware of all the other comorbidities that the patients will have. This is a very busy slide, but actually it's very easy to interpret. So what it actually says here is that for those patients, the numbers in the table represent the percentages of patients with the row conditions who also have the column conditions. So for example, 23% of patients with coronary heart disease will also have diabetes, and 54% of patients with hypertension will also have diabetes. Indeed, only about 17.6% of patients will have only diabetes. The vast majority of patients with diabetes have diabetes and something else. For patients over the age of 65, they will have a median of 6.5 other conditions in addition to diabetes. And those under the age of 65 will have a median of 2.9 other conditions in addition to diabetes. And so if you're a primary care healthcare professional facing these patients with all these conditions, thinking about all these guidelines makes it very complex indeed for you to follow. The other big challenge that contributes to this efficacy gap is non-adherence. Non-adherence is a huge problem, accounting for about 50% of chronic disease management in a year from diagnosis. And in Europe, it accounts for about 125 billion euros being wasted in the healthcare service. 3 out of every 10 patients prescribed medications stop them before the medications actually run out, and a quarter of patients take less than the recommended dose, and another third of patients do not fill their prescription their prescription requests when it's time to do so. And so the common causes of non-adherence normally will be side effects and difficulty remembering, and indeed in some cases the cost of their medications. So this study actually illustrates the predictors of non-adherence. And as you can see here, old age is a huge predictor of good adherence, whereas perceived side effects usually will be a big reason why patients will not be taking their medications. So we know about the ominous octet. One way of addressing non-adherence is to prescribe medications that target various organs at the same time. So if you've got a patient who needs to be on a diabetes drug, but that diabetes drug also addresses issues about blood pressure, weight, and kidney function, it might be reasonable for you to try to attack all these organs at the same time, not just in addressing glycemic control, but all the other extra glycemic benefits that the drugs could, deliver. In so doing, what you might find is that you'll be needing less and less of the other drugs for the other conditions, because the diabetes drug, which is attacking the glycemia, has also got all these extra glycemic benefits. And another way of addressing this is to think about non-adherence in two parts. First, at the point of initiating the drug, and the second, at the point of intensifying the drug for diabetes control. When it comes to initiating the drug, address non-adherence in primary care, actually, on discussion with the patient, you could agree on starting a medication that they only have to take less frequently. For example, if you've got a once weekly medication, it's counterintuitive to think of the fact that one that you'll be taking once a week will be a better option for the patient to consider than one that they'll be taking daily. From a qualitative study, this is a statement from one of the patients. I don't have to take, if I don't have to take the drug every day, I might as well, start taking it, because I'm only having to take it once a week. And so it's a lot easier for them to take. Similarly, when you control your glycemia and the A1C target is not achieved and you want to intensify treatment, it's a lot easier for you to give a drug that they only have to take once a day than one that they have to take multiple times a day, which leads me into the story about fixed dose combination. Fixed dose combination of treatment is not something that is popular in the United Kingdom for all sorts of reasons. But if you've got a drug that, a tablet that contains 2 medications at the same time, it makes it easier for you to intensify rather than adding an extra pill. The patient would say something like, well, I might as well agree to intensify treatment if I don't have to take an extra tablet, because that extra tablet is already built in a combined pill. And so it's easier for them to take. The other way of addressing, non-adherence is, even if it's taking single dose medications, it's important to consider options that they have to take once a day as opposed to one that they have to take several times a day. This is a study that looks at the odds of adherence to medications with their 95% confidence intervals. Those that they are taking once a day are more likely to be, taking than those that they have to take twice a day or even 3 times a day. Right. So moving on, there are a lot of other barriers that we haven't got time to go into detail, but things like hypoglycemia, I'll talk about side effects, quality of life of the patient, hypoglycemia, lack of time, financial restrictions, patient beliefs, insurance claims, and risk to other, patient comorbidities and complex regimes. All of these, play a very complex constellation of reasons on the healthcare professional at the front line in primary care, and for that matter, they will be unlikely to prescribe these medications. The other big issue is inertia. Therapeutic inertia is a huge factor in primary care. What we do in primary care is to start, diagnose a patient and put them on lifestyle modification, and the A1C comes down, but soon afterwards it goes up again, and then you add metformin, the A1C comes down again, and then it goes up again because of dwindling beta function from time after the diagnosis, or indeed because the patient become non-adherent, or for whatever reason, the A1C goes up again, and then you add another medication, and so on and so forth. So you get this stepwise approach, or seesaw of fluctuation A1Cs. Now, this is what is contributing to a high risk of cardiovascular disease. Patients who are, taking, medications that bring A1C down and then allow the A1C to go up again are likely to have fluctuation in the A1C, which contributes to high cardiovascular disease. And so the idea is to probably consider keeping the A1C flat from diagnosis and keep it as low as possible for as long as possible. Initially, you get microvascular benefits, and later on, you get the macrovascular benefits. So at the moment, what is happening is sorry, my slides are playing up. Just let me sort this slides up now. Yeah. So at the moment, what is happening is that with a stepwise approach, we have baseline A1C at somewhere around 8% or even more in some cases for a long time. What we need to do is to get primary care colleagues to push this curve all the way down and leave it there for as long as possible. This way we can achieve a flatter, smooth A1C without fluctuations and prevent those complications. And then finally, one of the biggest challenge that we have in primary care is that there is no co-production of these guidelines. So this is a study that we published a couple of years ago now, looking at all diabetes articles published and diabetes articles on randomized control articles in diabetes published. And then we compare that to all diabetes articles published and diabetes randomized control trials published in primary care. And as you can see from this curve, over the past 20 years, there has been an exponential rise in all the diabetes articles published. And indeed, for diabetes articles in randomized control trials has been rising as well. You compare those two curves to the corresponding curves in primary care, and you can see that over the past 20 years, that has been flat. So investment in primary care research has been lacking behind that of specialist centers. And so you don't have primary care academics getting involved and generating these guidelines. And so the guidelines that are normally generated are not suitable for them. They are not fit for the purpose in primary care. And so they are less likely to adhere to them. So another most effective way of implementing guidelines in primary care is actually to translate these guidelines into clinical pathways. So a few years ago, what we did was we looked at this case of non-adherence to guidelines in primary care setting and labeled it as the enemy of evidence-based medication. And in that publication, we suggested that clinical pathways, which we define as a structure multidisciplinary care plans, which detail essential steps in the care of patients with specific clinical problems, and that they needed to be based on local structures and systems and timeframes that address the recommendations in the guidelines. And so basically what you're doing is taking the guideline and translating it into local structures and systems and timeframes that will address specific recommendations in those guidelines. And these pathways normally, an example of how this has worked very well is what we have in Leicester. So we have our guidelines in the United Kingdom in managing type 2 diabetes, but over the years, we've known that these guidelines are not implemented locally properly. So what we did in Leicester was got all the stakeholders around the table and decided to reorganize the diabetes pathway in the city in such a way that very complex patients will be taken out of the equation and managed only in specialist centers in the pink box or red box. So these patients will be those with complex type 2 diabetes, complex type 1 diabetes, children, pregnancy, insulin pumps, renal patients, and diabetes feet or inpatients, all these patients under specialist care. Everybody else was managed in primary care, and we do appreciate that in primary care, not all the GPs will be interested in diabetes. Some might have an interest in dermatology or musculoskeletal medicine, and it will be impossible for them to get interested in diabetes and manage patients with diabetes. And so in primary care, we had two groups of practices. Those who were interested in diabetes, who had an enhanced service provided to their patients, and those who were not interested in diabetes and they only provided core service. Now, these practices were supported by diabetes specialists from specialist centers to provide a similar standard care across the whole city. And these practices implemented locally developed pathways based on the guidelines. And as a result of that, we're able to see benefits. The Leicester Diabetes Center is a huge unit with over 150 researchers in one building, sharing our research output and supported by our education team called the EDIN, Effective Diabetes Education Now. The EDIN team is able to develop educational models based on the research output, generated from the Diabetes Center. And with that, we're able to produce the outcomes that we are seeing in the city. To do this, you don't only rely on GPs in primary care. You need your specialist support, you need your podiatrists, you need your pharmacists, you need your healthcare professionals from all walks of life, all around the table to develop these interventions. And it's only when you do this at the same time that you can get benefits in glycemic control. And so in this paper that we published in Diabetes Research and Clinical Practice a few years ago, we're able to demonstrate that multifaceted professional interventions were more effective than single interventions targeting single primary care or community care professionals in improving glycemic control. And so I conclude by putting it in this table. So you have your patients with diabetes in the middle, the general practitioner, the diabetes specialist, the pharmacist, healthcare assistants, all of these primary care specialists work around the patient, to determine the patient's goals and then support the patient to achieve those goals. And of course, these primary care teams will be supported by their specialist colleagues, the nephrologists, the diabetologists, psychologists, podiatrists, and the cardiologists. So in conclusion, diabetes is now mainly managed in primary care, and there is a huge efficacy gap. And that can be addressed through tackling multimorbidity, adherence, avoiding inertia, and enhancing research in primary care. Thank you very much.